you. Well, we have a very exciting session with very good topics in this session. We have Dr. Arvind Gupta, who will be speaking on beta cell failure to dysfunction to dedifferentiation. So that's a good topic and little less discussed these days. And the second topic we have by Dr. Anu Mishra regarding the ectopic fat. And the third topic is by Dr. Vinod Mittal, where he will discuss about gut-brain link in the pathophysiology of diabetes. So I would first introduce Dr. Arvind Gupta, and then I will request my co-chairperson to introduce the second speaker. Dr. Arvind Gupta, of course, is very well known. He is attending practically every meeting connected with diabetes. He is the director and consultant of Jaipur Diabetes Research Center. He has been awarded several orations, including the RSSDI oration, where he got gold medal. And he's also a member of the RSSDI National Body Research Committee. With that, I will request Dr. Arvind Gupta to kindly give his talk. Thank you.
Thank you, sir. Shall I share my screen?
Yes, sir.
Yeah, my slides are visible.
Yes, sir.
Okay, let me have the presentation mode. Okay. Thank you, Professor Vinod Kumar. Thank you, Dr. Ripun. And thank you, Dr. Bansi, whole team of DiCare. I owe to them of my most of the clinical presentations. For this particular presentation, beta cell, it is a mix of molecular biology and the clinical implications. Because from clinicians' point of view, I want to give you the perspective of beta cell from failure to dysfunction to dedifferentiation. Probably how I understand about this topic, I will tell you in next 15 or 20 minutes. Beta cell, as we know, that if the natural history of diabetes, once the patient comes to us for the first time, especially for type 2 diabetes, I'm telling, 50 to 60% or more than 60% beta cells are already lost. And what we understand that the apoptosis of the beta cells are already there. Now, remaining rest of the 50% beta cells, now after the onset of diabetes, there is a sudden increase in the apoptosis of the beta cells, which we call as a failure of beta cells or beta cell failure. Now, there are multiple factors responsible for this beta cell failure. But recently we come to know through the molecular understanding of the beta cell that some of the beta cells go to the different types of the cells and they transform into different types of cells, remaining there as an inactive without having any secretion of insulin. And once like so many factors like glucotoxicity, hyperglycemia is relieved, they immediately again dedifferentiate to the active beta cells. So this is what we understand about the beta cell. And
Dr. Arvind, we are not able to see your slides are changing.
Okay, now it is changing. Hello.
Yes.
Yes, it's changing now.
Okay. So
now it's moving, sir.
Okay. So now the beta cells in the pancreas, if you see here a very clear picture of beta cell here, just have a pointer here, just a minute. Can I have a pointer? Yeah. Okay. So now if I say that beta cells comprises around 70 to 80% of the endocrine mass of the pancreas. If you see here very clearly, these are the beta cells which are the light blue color, and these beta cells comprise around 70 to 80%. While you see these beta cells are basically located in the central portion of the islets, and it produces the insulin and amylin. And insulin is released in response to elevated glucose, which I'll come into the later. But there are few other cells are also present. Like here, it is an alpha cell, which is a dark blue color, and delta cell, it is purple color. So if you see here, it is a mix of beta cells, alpha cells, and delta cells, and how they transform here. If you see the islets of the Langerhans here, that the most of the cells are here. These are the alpha cells here, and the beta cells, most of the 70 to 80% comprises of the beta cells, and the dark color here, it is the delta cell. We know alpha cells, they secrete glucagon, beta cells secrete the insulin and amylin, and delta cells secretes the somatostatin. But it is a beautiful transformation between these three cells regularly occurs during the whole day period time or in the metabolic milieu. And what is the beautiful things here, that they transform or they change to the other cells according to the need of the metabolism. So if you see what is the metabolic need, suppose a person needs the the person, if the glucose is going up, we need glucose is to be going down. And once the glucose is going down, we want to, there is a nature which causes the hypoglycemia to again in the normal glycemia. So how the normal glycemia maintains, that is a beautifully changing between alpha cell secretion, delta cell secretion, and the beta cell secretion. So we know about this thing very well from the physiology and for last so many years about the natural history of progression of the type 2 diabetes. And what we see here, the beta cell function, we know right from the day one, the beta cell function reduces steadily, irrespective of whatever the situation may be. But this is insulin is rising initially, hyperinsulinemia occurs, and once at the onset of diabetes, then there is a gradual decline in the insulin secretion. Hepatic glucose production, if you see here, steadily rise before the onset of diabetes, and once after the diabetes, there is a steadily, there is a plateau of secretion, hepatic glucose production. If you see the postprandial glucose here, initially the postprandial glucose is right, and even after onset of diabetes, the postprandial glucose is rising. However, the fasting glucose is also rising immediately after the onset of diabetes. So this particular point is known as point of no return, especially for the beta cells. So let us see what happens in the natural history of diabetes. If you see here, very clearly here, like if I want to see here the mean plasma glucose, plasma insulin during the oral glucose test here, if you see here, this is how in the natural things here, this is the plasma insulin here, this is the insulin mediated glucose uptake here, and this is a beautiful natural the mechanism of keeping the person into normoglycemia. This is a classical example of Belfast diet study where two phases of beta cell failure have been seen. If you see here, what this study suggests to us, that there is a 1.7% decline of beta cells, the decline per year. That is what we found the beta cell functions. So whatever we do, there is a 1.7% decline per year in any person's life. Once after the diagnosis of diabetes, there is a sudden decline of around 18.2% decline per year. So there are these phases. This is a phase A is the slow decline, and phase B is the fast decline. And this depends on multiple factors. and we know some of the factors very well. So what are the events in the failure of beta cells? We have to understand this phenomena very well. If you see here, this is the healthy beta cells with lot of PI granules which secrete the insulin. This is the stress beta cell where we see the PI granules are much more. Means if you stimulate the beta cells, the insulin PI granules are much more and they secrete more insulin. But if you stress these beta cells continuously, then what will happen? This will cause the failing beta cells. And this failing beta cells will mean very little PI granules which secrete the insulin. Now, this failing beta cell is very, very intelligent, and nature is very intelligent in our body. What it does, it transforms to dedifferentiation. So the cells become almost inactive without having any action or any secreting beta cells, and they become dedifferentiation. I'll tell you little details little later on. But if there are certain beta cells which can go into the apoptosis and death, that means what is then in the natural history of diabetes, we see when there is a normal glucose tolerance, the beta cells remain healthy. But in the case of beta cell compensation here, there is a stressed beta cells, and once this impaired glucose tolerance goes into the glucolipotoxicity or insulin resistance and severe inflammation, in the event of type 2 diabetes, these beta cells fail and some beta cells dedifferentiated. Now, there are different models of beta cell failures in type 2 diabetes. And we just see here, this is a normal islets of Langerhans, whereby the glucose stimulates the beta cells. It enters through the blood receptors. Here inside goes into the mitochondria. There is a cascade of events, and then through the stimulation of the PI granules, the insulin is secreted. But what happens when you have a reduced number of beta cells? Naturally, smaller beta cells or defective beta cell proliferation or beta cell death occurs. So that causes the reduced beta cell. But in cases of endoplasmic reticulum stress, or in the case of severe oxidative stress, now this glucose goes, of course, stimulates these beta cells, but unfortunately, the cells do not secrete the insulin. That is meaning of dysfunction. Means these beta cells are now have not the capacity of increasing insulin secretion in spite of hyperglycemia, in spite of the glucose stimulation. But I told you there is a third possibility, which is known as dedifferentiation, or there is a loss of identity or transdifferentiation, and this is known as compromised identity. These cells remaining in the pancreas for a longer period of time, and once the ER stress, oxidative stress, or hyperglycemia, or whatever we called as glucotoxicity, once this glucotoxicity is gone, these beta cells again transforms into the normal healthy beta cells. This is how the mechanism of beta cell compensation occurs. We have either we have the overnutrition, sedentary habits, insulin resistance, or fuel surfeit, means overfuel if we have. So it has so many actions on fat, liver, intestine, and brain. And through these mechanisms, either the fuel and neurohormonal signals through the increased free fatty acids in the circulation, increased triglycerides, glucose, amino acids, and so many fuels are there. They are actually going to the beta cell receptors and metabolic pathways through either triglyceride fatty acid cycling, through the anaplerosis, through the GLP-1 receptor agonist here, through the insulin receptors, or through the ADR and PT receptors. So what will happen? Ultimately, the beta cell growth and secretion coupling factors occurs, either defect in the fatty acid signaling or in the defect in the biosynthetic process, or PK beta or other insulin receptor signaling defects, insulin again resistance receptors substrate defects, or through the NPT signaling. Ultimately, these beta cells are known as beta cell compensation or enhanced beta cell function or increased beta cell mass. This is what happens when you have a compensated or during the period of hyperinsulinemia. But if this prolonged hyperglycemia continues, so what will it do? The continuous hyperglycemia induces the oxidative then and hypoxic state, as well as the cytokine exposure in the pancreatic beta cells. So if you see here, this hyperglycemia through the oxidative stress, ER stress, hypoxic stress, and cytokine induction, it either causes beta cell into apoptosis, whereby the less number of beta cells and the function also reduces. Through the failure of proliferation of the beta cells, also there is a less number of beta cells and functions. But there are two beautiful natural phenomena occurs in the pancreas, that is known as autophagy and dedifferentiation. So these, because of these two mechanisms also, the less number of beta cells and functions, but these through the autophagy and dedifferentiation, these cells remaining. And ultimately, if this continues, the beta cell failure occurs. So initially there is a dysfunction of the beta cell. If the hyperglycemia continues, glucotoxicity continues, there is a beta cell failure. And this is how the beta cell fails. Because of the fuel surfeit here, beta cells are stressed. There is a compensatory growth of the beta cells. So robust beta cells and sustained adaptation, and causes normoglycemia. But if for the susceptible beta cells, there is a beta cell dysfunction and ultimately leads to beta cell failure. There are so many factors responsible for susceptible beta cells, so many factors responsible for beta cell dysfunction, and so many factors responsible beta cell failure. Now I can enumerate. Type 2 diabetes, it is a progressive role of glucolipotoxicity, oxidative stress. So as a clinicians, if we see these particular factors, if we remove or if we reduce these particular factors, we can actually cause less beta cell failure in our patients. So this is the typical phenomena of dedifferentiation. How the dedifferentiation occurs in the nature. Nature is so clever beyond our expectation. Stem cells convert into the definitive endoderm cells. And these endoderm cells, either in the pancreatic multipotent cells or acinar cells, through the different enzymatic action, pre-endocrine cells develop, and these pre-endocrine cells develop either beta cells, delta cells, or alpha cells. And they are interchangeably sometimes, and I'll tell you little detail later on. So what happens? How the metabolic stress causes the loss of beta cell identity. I'll not go into the details, but very importantly, beta cells are dependent on multiple transcription factors to be active to maintain their identity. That is very important. So many factors. For example, a deletion of PDX1 in adult beta cells lead to loss of beta cell specific genes and to the induction of alpha cell genes. So some of the genetic mechanisms or genetic things are there, like deletion of PDX1, which actually causes from beta cells to alpha cells. Deletion of NKX6.1 in adult beta cells led to loss of beta cell specific genes and functions. And deletion of PAX6 in adult beta cell leads to gradual loss of insulin expression. So there are certain genes which are responsible for dysfunction or failure of the beta cells. So how this hyperglycemia induces the deactivation of PAX6 leads to activation of non-beta cell genes. Clearly see, it is a chronic hyperglycemia. Through the PAX6 genes, through the beta cell gene expression here, the beta cell function goes down, and through this some non-beta cell genes are also there, and through this the dysfunction of the beta cells occurs. So my dear friends, just this is very, very important to understand, and from the clinician's point of view, this is also very important. The de-differentiation of the beta cells via epithelial mesenchymal transition has been reported by several studies, and a large number, like more than 80% of insulin negative and chromogranin A positive cells, it is a marker of committed endocrine cells, are observed in the pancreatic islets of the animal. This is animal studies, of course, and such cells also express endocrine progenitor markers like neurogenin 3, NGN3, synaptophysin, which suggests that they are losing beta cell identity. So the de-differentiation, I just give an example here. This is the plasticity of cells and the beta cells, alpha cells. The conversion of cell fate between alpha cells and beta cells termed as transdifferentiation. This is a transdifferentiation from alpha cells to the beta cells. And so many factors here responsible for conversion of alpha cells to beta cells, and again from beta cells to alpha cells. The most important proteins responsible for this transition is the transcription factors paired homeobox 4, which is known as PAX4, and Aristotelis related homeobox ARX. So these are the few transcription factors which are responsible from interchangeability of alpha to beta cells and beta cells to alpha cells. So, but there are certain intra-islets.
I'm sorry.
Yeah, I'm just going to the last one or two slides.
Okay.
I think this is very important to understand. Just I want to have the FOXO1. This is again very important. This is how the beta cell goes into the interchangeability of different types of de-differentiation of different cells. Like here, it is the one of the important thing is hyperglycemia. So let us see. This is the most important thing. The FOXO1 protein. This is Forkhead box protein 01. This inhibits the beta cell replication. So probably the most rate limiting factor here is the FOXO1, which inhibits the beta cell replication by upregulating the expression of cell cycle inhibitors and suppressing PDX1 transcription. So particularly this FOXO1 inhibits the beta cell neogenesis. It protects beta cell against oxidative stress and also prevents the de-differentiation and maintains the beta cell identity. So this is how the FOXO1 actually helps in maintaining the beta cell identity in our normal metabolic milieu. So this is how this beta cell through the FOXO1 here, this is through metabolic stress here, this beta cell is now growing and de-differentiated here. And if the environment is favorable, this de-differentiated beta cells again re-differentiation into the alpha cells. So this is how in the normal thing. So from a clinical perspective, stress beta cells in diabetes may lose beta cell markers and gain markers of alpha, delta, ghrelin, and gastric levels. The islet endocrine identity appears to be robust. Compromised beta cell identity is emerging, and loss of beta cell identity and acquisition of features of non-beta cell genes appear to be reversible. So there are different factors, but ultimately how we understand as a clinician regarding this transition is that there are certain factors like glucotoxicity. If we relieve the glucotoxicity, the cells which have been de-differentiated, they again re-differentiated into the active beta cells and can remain into the beta cell secretion. So my dear friends, prolonged hyperglycemia leads to oxidative stress, ER stress, hypoxic stress, and cytokine induction. So you have to relieve hyperglycemia as early as possible to maintain the beta cell identity. Multiple transcription factors are involved. Still, it is a research area to maintain the identity of beta cells, and what we can do in the clinically, it is still to be known. So FOXO1 plays the very important role in dedifferentiation and redifferentiation of the beta cells, and reprogramming of other cell types to beta cell is a possibility, can be a potential treatment option for beta cell in the future. Let us hope some beautiful experimental and clinical and research regarding if we can convert some of the non-beta cells to the beta cells through the understanding of molecular mechanisms. Thank you very much, sir.